Ken, thank you very much. I think it's great that we can all get together with our closest friends and talk frankly about mucus. I also, I think the work that Ken just showed is some of the most important and outstanding work that's been done in the recent past. And for many of you, that work will probably answer some important questions about why you have what you have. What I tell my patients, and I apologize to them in advance, is in a few years, you can go down to Walmart, spit in a cup, put $10 in a machine, and you'll get your genetic code. And that's when we'll know exactly what Ken is talking about. So to further our discussion about mucus, we have the return of Dr. Tino from Penn, talking about evaluating and treating bronchiectasis patients.
So Dave's admonition to me was make it quick. So I'm going to try to do it in 10 minutes. I'm kidding. So I'm going to give you really a bird's eye view of the approach to evaluating and treating our patients with bronchiectasis. Thank you. Thanks very much. All right, so these are my disclosures, some of which are no longer relevant. So Dr. Axman has already alluded to what bronchiectasis is, and quite simply, from a pathologic perspective, it's a disease that's characterized by permanent airway dilatation and airway inflammation, and what the patient feels is chronic cough, chronic sputum reduction, and usually recurrent respiratory tract infections. You've also heard that it's very heterogeneous as an entity with multiple etiologies, which we'll learn about some more as the talk goes through. And interestingly, mirrors the experience of NTM, bronchiectasis appears to be increasing in prevalence, not only in the United States, some nice data from Dr. Olivia's group at the NIH, but also mirroring the experience in Europe with recent publications. And very uniquely, it's a disease that's punctuated by exacerbations, and these are typically acute events, typically acute infections that require a change in treatment and can be quite devastating to patients, not only in the short term, but in the long term, and it's a disease that's associated with significant impairment of quality of life and ultimately significant morbidity and mortality. So how do we evaluate patients with bronchiectasis? So the first thing is to get the diagnosis right, and I think there's really two parts to that. One is to establish that a patient has bronchiectasis, and this can be a little bit more difficult than it seems, and usually by the time patients get to us, they've had symptoms for an extended period of time. You've heard about the work about phenotyping. I think phenotyping is a very important concept and really will, I think, help direct therapy moving forward. But I think an important endeavor is to identify specific underlying causes using an organized diagnostic approach, which I think is successful in a majority of cases of identifying specific causes. And why that's important is that it may impact therapy in as many as 40% of the patients with across-the-board bronchiectasis. And this is a little schema that I've used. It really starts with the patient, the history. The patient tells you that they have bronchiectasis. You have to ask the right questions and think about that possibility, and then establish the diagnosis with chest imaging, particularly the thin section CT scan, and then use the clinical history that you identify to really decide on what other diagnostic studies you need to do to identify potential underlying causes. And finally, and this always makes Dr. Noon very happy when I talk about the importance of sputum analysis, again, not only to help direct therapy, but it may have specific implications about specific etiologies. So what are some of the clinical profiles that we look for? Well, certainly patients who present with persistent productive coughs, 1, 2, 3, 4 tablespoons a day. Not everybody does, but most people do. Symptoms for many years, and if you ever get a sputum culture that shows Pseudomonas for a patient who shouldn't have Pseudomonas, that patient probably has bronchiectasis until proven otherwise. If you have older women who have recurrent respiratory tract infections, 2, 3, 4 times a year getting antibiotics, think about bronchiectasis. The patients we see not infrequently are patients who carry the diagnosis of COPD. The problem is they're not smokers, and it's unlikely that they have what we classically identify as COPD. They're treated for exacerbations. Ultimately, they have bronchiectasis, and every once in a while you see a patient who presents with unexplained hemoptysis, and that patient too will have bronchiectasis. Again, the thin section CT scan is really important. You can see in both panels there the bronchial dilatation and significant bronchial wall thickening that's characteristic of bronchiectasis. And if you see how nicely it reflects this is a gross picture provided by my friend and colleague, Dr. Hewitt. You can see that the CT scan really identifies and really, in an imaging format, really shows you what we see under the microscope or grossly in patients with bronchiectasis. I find the CT scan always very helpful because the radiographic distribution, i.e. is it focal disease or multifocal or diffuse disease, helps me decide on potential causes. So patients that have focal disease, localized to one area or one lung, really the differential diagnosis is quite small, as you can see on this panel. And in general, focal disease is rarely due to genetic causes like cystic fibrosis or PCD or immune deficiencies, and it really is relatively limited to this list. And this is a patient that we saw at Penn a few years ago, a patient with bronchiectasis localized to the couple of lobes in the right lung. The soft tissue mass that you see there in the right proximal airways gave us a hint that this patient had bronchiectasis related to bronchial obstruction, and this patient actually had a bronchial carcinoid tumor that was resected endoscopically and did well. And this patient's bronchiectasis probably resulted from that airway obstruction. The same is not the case for multifocal or diffuse disease, where you see a larger number of entities, a more heterogeneous group of entities, and again, you can group them in many different ways. There are many different ways that have been published. This is one way, but again, you have to cast your diagnostic net a lot wider when you deal with patients in general with multifocal disease. The CT scan is also very important because not only can establish the presence of bronchiectasis, but in some cases, or if not many cases, the CT scan gives you the answer, or at least it gives you a very important clue about what the diagnosis is. And this is a patient that you all recognize with right middle lobe and lingular nodular bronchiectatic bronchiectasis, and this is a patient with MAC. This is a patient with severe upper lobe cystic bronchiectasis. This is a patient with cystic fibrosis. This is a patient who has ABPA. This is a patient with central bronchiectasis with classic mucoid impaction. We don't see this often in patients with ABPA, but when we see this, you've got your diagnosis. This is a patient with, again, a rare condition known as Meniere's-Kuhn's disease. This is congenital tracheobronchomegaly that can result in bronchiectasis. And this is one that we see not infrequently in our older patients. This is a patient with lower lobe bronchial wall thickening and bronchiectasis and a lot of tree and bud, i.e. bronchiolitis, and this is characteristic of GERD with acid aspiration. So again, the CT scan gives you a lot of clues, not only about the presence of bronchiectasis, but about potential causes. And then it's our job to go back to the patient. And there are a number of things that I look for when I approach a patient with bronchiectasis. How old are they? So younger patients, under the age of 40, we think of cystic fibrosis and PCD and ABPA and immune deficiencies. And as you get into the older age groups, things like GERD and aspiration, NTM, et cetera, start to predominate. The presence of extrapulmonary signs and symptoms of inflammatory bowel disease, of connective tissue disorders like RA, are also very important clues. And if they've got pre-existing conditions, a patient with ABPA who's had difficult to control asthma, who now presents with cough and chronic sputum production and purulent sputum production, again, the clue here is that patient has developed bronchiectasis. Similarly for patients with RA. And again, the microbiology can be very important. A patient who's got persistent isolation of Staph aureus, you think about cystic fibrosis, and to a lesser degree with ABPA. So this is really a challenging diagnosis, but start with the presence of symptoms, identify that patient has bronchiectasis, and then use other radiographic and clinical clues to at least nail down the possibility of specific underlying conditions. So one of the things that we've talked about and people have written about is, so how do you work up a patient with bronchiectasis? So the ERS published some guidelines, and these are based mostly on expert opinion. These are conditional recommendations based on really low quality of evidence that's been published, and they propose what's called a minimum bundle. So your patients with bronchiectasis should get a CBC with differential count, looking for eosinophilia and or lymphopenia. They should get serum immunoglobulins to identify underlying immune deficiencies. They should get ABPA testing with a serum Ig level, other serologies for aspergillus as well as an aspergillus skin test, and again, the routine sputum culture for the reasons that I mentioned before. So this is called the minimum bundle, and obviously other testing should be undertaken as dictated by clinical and other data. There are some recommendations both from the BTS and the ERS about how to evaluate or who to evaluate for cystic fibrosis. The BTS guidelines that were published now almost 10 years ago suggest that they recommend that CF testing, both sweat chloride studies and CFTR genetic mutation analyses, be done for all children and adults with bronchiectasis who are 40 or younger. And in older patients, consider CF testing with those with upper lobe bronchiectasis, that CT scan I showed you before, those who've got persistent isolation of staph in their sputum, patients who complain of a lot of GI symptoms suggesting malabsorption, men with male primary infertility, and patients with unexplained recurrent pancreatitis. And I've seen examples of each of these or some of these clustered that have led to the diagnosis of cystic fibrosis. In terms of PCD, and we've got a couple of real worldwide experts in the audience and speaking today, and again, some very interesting and important historical things to gather from your patients. Neonatal respiratory distress is really very, very closely associated, almost universally present in patients with PCD. Chronic sinus disease and otitis and infertility or dextrocardia are also obviously very important clues. In general, for older patients, workup for gastric aspiration, especially when they have the CT scan that I showed you before, should really be strongly considered, and we do this quite often in our older population in our center. People ask, when I speak about this, about the value of bronchoscopy. Really, bronchoscopy as a diagnostic tool for bronchiectasis is really not routinely warranted, and bronchoscopy is best limited to those patients where you're looking for causes of hemoptysis, for example, or if you're looking for lower respiratory tract pathogens, including NTM. So I'm going to turn my attention for the last 15 minutes or so towards treatment. So whenever we think about what treatments to employ in diseases that impact our patients, really it's what are the goals? And some of these are easy. So to control symptoms, particularly to reduce cough and to reduce sputum volume and sputum purulence and sputum viscosity. In bronchiectasis patients, reducing exacerbations, which I'm going to define in a minute, is very important. The clinical course is punctuated by these, and the more frequently you have them, the bigger the impairment of quality of life and probably impact on long-term natural history. It's obviously to improve quality of life. In some conditions, though it's harder to achieve in bronchiectasis, it's maintenance of lung function and then reducing mortality. And what we've learned over the years, both in the United States and elsewhere, is that the cost of care per patient and as a societal burden is really quite expensive. The presence of bronchiectasis, when you control for other comorbidities, increases the cost of care by several $1,000s per year per patient. So important goal, but difficult to achieve thus far. So how do we approach the treatment? And I'd like to think about this as really looking at that vicious cycle hypothesis that Dr. Axelman referred to and really deciding what are we trying to target? What are the treatment targets that we would like to employ? So one target is we know that patients have impaired sputum clearance, so what can we do to improve that? And I'll talk a little bit about the data that's out there about airway clearance. The mainstay of bronchiectasis and the treatment of bronchiectasis forevermore has been the treatment of infection, both acute exacerbations, and to treat chronic lung infections with a number of difficult bugs, including Pseudomonas aeruginosa. We know that airway inflammation, predominantly neutrophilic, but in other cases eosinophilic and otherwise, we know that that's really a hallmark of the disease. So what do we do and what can we do to reduce airway inflammation? And then again, finally, to treat the underlying condition. So let's take it from the top. First of all, if you look at what treatments are employed, both in the United States and elsewhere, what you will learn, as we did through our bronchiectasis research registry, is that there's great variability among the treatments employed. So we looked at our first 1,826 patients with bronchiectasis who were enrolled in our registry between 2008 and 2014. And these are data from expert centers. These are people that really do this, centers that do this on a regular basis with well-established programs. And you can see that the application of treatment is very variable. About half patients employed some kind of airway clearance. About 40% of patients only took antibiotics for exacerbations. Another 40% were on suppressive antibiotics, some on rotating oral regimens, some on aerosolized or inhaled antibiotics. Inhaled bronchodilators, for which there's very little written about the efficacy, was employed in about 2/3 of patients. Inhaled steroids about 40% of the time, and systemic steroids 13%. So again, really no consensus, even across expert centers, as to what treatments should be universally or consistently applied in bronchiectasis patients. So let's start with airway clearance. So airway clearance refers to a group of techniques that are designed to enhance mucociliary clearance. And as Dr. Flume will discuss a little bit later, these are not only widely considered, but I think for all of us, they are a mainstay of treatment for the management of bronchiectasis. The problem is we have little data to prove that. And it's not because we've got big studies that shown it doesn't work, is we don't have enough studies. And the studies that are out there are small, with small numbers of patients, for only limited periods of time, for 3 to 6 months. So hard to make conclusions based on the literature, but from our collective experience, not only for cystic fibrosis, but also in non-CF bronchiectasis, airway clearance is critically important and probably the intervention that I employ most often when patients are referred to me, even from other pulmonary docs. Now, there are a number of modalities that are in use, and again, I'm not going to get into these in detail because Dr. Flume will. There are a number of mechanical methods, including vibratory PEP valves, high-frequency oscillation devices. In general, the vibratory PEP valves are the most commonly employed. We learned that through the U.S. Bronchiectasis Research Registry, and I think it mirrors our clinical experience at our centers. And then there's some pharmacologic methods, particularly hypertonic saline, again, which Dr. Flume will talk about. I think the take-home message about airway clearance is, in terms of the target population, really symptomatic patients, those with chronic persistent cough and sputum production, people who say, you know, I'm congested, I know it's down there, I just can't get it out. So the patients who complain of difficulty expectorating sputum are and should be treated with airway clearance. And those who have frequent acute exacerbations, again, very important part of the treatment. Which one is better? Well, we don't have that data. We just don't have comparative data across a spectrum of modalities. And in general, what I ultimately recommend is a modality that will maximize the patient's adherence, that the patient finds most helpful, and that they will do in the long term. Again, more to hear from Dr. Flume. We talked about antibiotics being the mainstay of the treatment of bronchiectasis. So we've talked about exacerbation. So what is an exacerbation? And I've said this many times, an exacerbation of bronchiectasis is something that I think we can easily identify in clinical practice, but how we define it for a number of purposes becomes a little bit more challenging. And I can tell you that there were many, many discussions as clinical trials were being defined and designed around inhaled antibiotics, lots of discussion about how to define an exacerbation. So this is work that was published in the European Respiratory Journal a couple of years ago. This was a consensus statement using a Delphi method that we used from colleagues from the our EMBARC colleagues in Europe, as well as our United States Bronchiectasis Research Registry, and we came up with a definition for a pulmonary exacerbation that specifically was going to be employed for clinical trials, but clearly has wider applicability in clinical practice. So an exacerbation, as defined by this consensus definition, is a person with bronchiectasis who has a deterioration in 3 or more of the following symptoms for at least a couple of days. So changes in cough, changes in sputum volume and/or consistency, change in sputum purulence, breathlessness, development of exercise intolerance, and then systemic symptoms like fatigue and malaise, as well as hemoptysis. And this is a point that we talked about a lot, and that a clinician determines that a change in bronchiectasis treatment is required, whether it's intensification of airway clearance, whether it's the initiation of systemic antibiotics, which is usually what we do in these circumstances. This is what is at least the working definition of an exacerbation. Again, sputum analysis is critical. What we learned over the years that the most important pathogens, or the most frequently identified pathogens, are Haemophilus species and Pseudomonas. You can see in different studies there. But again, in about a quarter of our patients, even with sputum analysis, we don't identify a dominant pathogen. And again, it underscores the importance of making an empiric antibiotic choice for our patients. And more recently, the U.S. Bronchiectasis Research Registry, again, about 33% of our patients had chronic infection with Pseudomonas, and staph in about 11%. So again, we can talk about antibiotic therapy in the long term, but I just want to leave you with some general principles. Again, let sputum analysis be your guide. When you use an empiric antibiotic, if it's a quinolone, the recommendation is really to adjust and narrow your antibiotics if a specific pathogen is identified that does not require a broad-spectrum quinolone. The optimal duration for antibiotic therapy once you initiate it is uncertain. Again, the recommendations from the ERS, again, a conditional recommendation based on low quality of evidence, is at a 14-day course. I think that's reasonable. But longer courses, an extension of the course to 21 or 28 days, as dictated by clinical response, is really what most of us will do. And the Pseudomonas story and the Staph aureus story, again, these are infections that are especially challenging, and I'll talk about some of the data about inhaled antibiotics in the next few minutes. So, inhaled antibiotics. So, it's trite to say that having bacteria in your airways is not a good thing for you. So high bacterial load measured by colony-forming units has been linked to the risk of future exacerbations in patients with bronchiectasis, higher rate of hospitalization for exacerbations, and it correlates with markers of lung inflammation, so that the theory, and again, makes sense, is if you reduce bug burden, will that have a salutary impact on our patients? And the focus has been specifically on gram-negatives and even more specifically on Pseudomonas infection. There's a tremendous amount of data talking about the adverse impact of the acquisition of Pseudomonas on the natural history and prognosis in patients with bronchiectasis. This is rather stark data that's from Europe, and that what it illustrates here, and this is from Dr. Chalmers' group and others, that the impact of Pseudomonas infection is profound. 7-fold higher risk of hospitalization if you've got Pseudomonas relative to other bacteria, and significantly higher mortality compared to even other gram-negative rods and some of the other gram-positive organisms. So this is garnered and deserves a lot of attention as a phenotype of patients with bronchiectasis. What we know is that inhaled antibiotics have really been the standard of care now for 20 years in cystic fibrosis. The tobramycin story, now a classic paper by Bonnie Ramsey in the New England Journal 20 years ago, and more recently the approval of aztreonam in patients with cystic fibrosis. And inhaled antibiotics really have some very, very important and some very, very advantageous characteristics. When a drug is given in the airways by inhalation, you get high concentration in the airway, so you get it where you want the effect to be. And importantly, this leads to a reduction in systemic absorption and clearly reduction in systemic toxicity. And when you're talking about, for example, aminoglycosides, that's particularly important. Now, there are some downsides. We'll talk about the sort of the classic airway side effects that occur in a fair number of patients who are on inhaled antibiotics. And one of the things that's been concerning infectious disease specialists and microbiologists, and as well as us, is the possible emergence of clinically resistant pathogens, which I think is obviously an important thing. Now, the good news is that over the last 15 years or so, there have been a number of very well conceived and very well designed and very well carried out clinical trials with a number of different agents, and you can see them on this slide. The more recent data has been specifically with colistin and both dry powder ciprofloxacin, which is the subject of 2 large clinical trials, the Respire trials, as well as liposomal ciprofloxacin, again, large-scale clinical trials, 2 concurrent trials, the Orbit trials. Again, I don't have the time to go over each one of these individually, and just wanted to summarize the data as exists as of now. So there is no question that regardless of the antibiotic that's been studied, that there is a clear microbiologic impact. The reduction of colony-forming units across the board is dramatic, and it's even more dramatic than one sees in patients with cystic fibrosis. In general, again, I've alluded to the fact that there's been lots of debates as to what is the appropriate clinical endpoint, and for a number of reasons, exacerbations and reductions of exacerbations has been chosen as the primary endpoint in the majority of these studies. And unfortunately, despite the well-conceived nature of these studies, the clinical efficacy has not been proven conclusively, at least not to generate approval by regulatory agencies. There have been studies that have been shown reduction in exacerbations. A very nice study by Dr. Hayworth using inhaled colistin. The Respire 1 and Orbit 4 trials also demonstrated significant reduction in exacerbations. Unfortunately, that was not demonstrated and corroborated with their companion studies, Respire 2 and Orbit 3. And colistin is now the subject of an international clinical trial as well. There have been signals that the use of inhaled antibiotics is associated with improvement in quality of life. And again, the colistin study showed that there was a significant improvement in the St. George's Respiratory Questionnaire after 26 weeks. And the improvement was on the level of about 10.5 units, which really meets and exceeds what is the clinically minimal difference in terms of statistical significance. In terms of the adverse effects, again, these are very well described: cough, dyspnea, dysphonia, in some patients, frank bronchospasm. These have been well described and can be limiting in their use, and the aztreonam trial was an example of not only was there an issue with absence of efficacy, but the burden of adverse effects really, I think, minimized the impact of that drug long term. We've talked about and written about and argued about the emergence of resistant pathogens. Clinically resistant pathogens that are of concern to individual patients or society have not been observed, but this is going to remain a long-term concern. And unfortunately, none thus far have been currently approved by our regulatory agencies. So most of us use inhaled antibiotics on an off-label basis, and I think they work in selected patients, but we need more research and more data about the conclusion for inhaled antibiotics. And who do we use inhaled antibiotics? Well, certainly the frequent exacerbator phenotypes, so patients who have chronic gram-negative infections, who have frequent exacerbations, typically more than 3 a year, and in the setting of other treatment being optimized. But there, again, lots of unanswered questions. Should you use these drugs daily, or should you use them 28 days on or off? as is oftentimes used in cystic fibrosis. And how about chronic macrolides? I'm going to show you some data about the impact of chronic macrolides. So what do you use first? Do you use inhaled antibiotics or chronic macrolides? Again, this has really not been established, just beyond expert opinion. So inflammation, as broadly defined, as I mentioned, is an important part of the pathobiology of bronchiectasis. And it turns out that macrolide antibiotics across the board have really myriad anti-inflammatory and immunomodulatory properties that really enhance the scientific plausibility of using them in bronchiectasis. And again, these effects include inhibiting mucus hypersecretion, reducing IL-8 neutrophil elastase levels, inhibiting neutrophil adhesion to epithelial cells, importantly, inhibiting biofilm formation that we've heard about before, and the impact of biofilm formation and hiding the bugs from antibiotic therapy, inhibition of production of reactive oxygen species, all of which, again, from a scientific standpoint, if you can impact any one of those or in combination, should have a positive impact. And frankly, there's been a precedent for the use of macrolides in other airways diseases, like cystic fibrosis, like diffuse panbronchiolitis, like obliterative bronchiolitis in the post-transplant period, and as well as recent data published in COPD. So it turns out that in terms of the treatment modalities that are out there, probably the evidence for the use of chronic macrolides is probably the strongest that we have. So again, time doesn't permit me to go over these studies in great detail, but between 2012 and 2014, there were 3 excellent trials published in high-impact journals that looked at the impact of macrolide therapy on the frequency of exacerbations, 3 different countries, a couple of different drugs, 2 used azithromycin, 1 used erythromycin, some changes or some differences in their inclusion criteria, but in general, the conclusion is that all 3 studies reported a decrement, a significant decrement, statistically significant decrement in exacerbations. Now, there are obviously some concerns with the use of macrolides in the long term, including bacterial antibiotic resistant. Very importantly, the adverse impact of monotherapy on patients who are known or suspected of having NTM. There are cardiac risks. There's a paper published in the New England Journal several years ago. The cardiac risk of sudden death is actually quite small across a population of patients. They should be used with caution with patients who have QTc prolongations and other cardiac rhythm disturbances, but in selected patients, the risk is actually quite small, and other adverse effects, including the GI tract and ototoxicity, that you have to at least be aware of. Again, in terms of who to think about using macrolides in, again, it's that frequent exacerbator group, but we don't have any subgroup data or the role in other clinical settings. Again, I would look to make sure that those patients that you choose don't have significant underlying cardiac disease and have a normal EKG and QTc. Can't make this point strongly enough, and this is known to everyone in this room, is to avoid monotherapy in patients with known or strongly suspected NTM infection because of the adverse impact on natural history and mortality in patients who develop macrolide resistance. And again, one of the clinical issues is how long do you put patients on therapy? And in general, the studies have been up to a year. And I tell patients that once we do that, if they tolerate it well, that those patients are going to be on it for a minimum of a year, and then we'll develop a discussion about that depending on how they do moving forward. And I now have several patients who've been on them for several years. So the ERS took a shot at trying to get an algorithm together about what to do with patients who are frequent exacerbators and whether use macrolides or inhaled antibiotics. And what they've proposed is, if you've got a patient with frequent exacerbations who are otherwise on good therapy, including airway clearance, et cetera, so they tend to use long-term inhaled antibiotics in those patients who have Pseudomonas infection with frequent exacerbations. In their non-Pseudomonas patients, they prefer and start using long-term macrolide therapy, but if there's absence of efficacy or intolerance, again, there's a symbiotic relationship between inhaled antibiotics and long-term macrolides, and in some patients who have a partial but not the kind of response you'd want, in some cases there's a paradigm to use them in combination. Again, this is evolving, but this is what's out there both in clinical practice and what's been published. A couple of things that we don't recommend. One is, again, inhaled corticosteroids, unless there's a compelling reason for people to be on inhaled corticosteroids for a number of reasons, but as emerging data that there's an increased risk of NTM infection. Chronic systemic corticosteroids, again, unless they're dictated by the treatment of the underlying cause, like ABPA, should be avoided. And for a long time, the use of rotating antibiotics, which one of my mentors had talked to me about 30 years ago, we've really moved away from that and really discouraged the use of chronic non-macrolide suppresses systemic antibiotics. So surgery does have a role in selected patients. John Torrance told us a little bit about his experience. Certainly it's an option for localized disease and those who have frequent exacerbations despite aggressive medical therapy. It can be used as an adjunct to medical therapy for NTM infection, as our National Jewish colleagues have really a huge experience with that, or those with refractory massive hemoptysis. And in general, in well-selected patients, surgery can be done with quite acceptable morbidity and mortality. Other measures which are important, again, specific therapy for underlying conditions when it's appropriate. Short-term, short-course systemic steroids for patients who've got a lot of areas reactivity in the setting of an exacerbation can be helpful. Conditioning regimens like pulmonary rehab, obviously supplemental oxygen, and for those advanced patients, lung transplantation really can be done with good outcomes in patients with advanced bronchiectasis. So in summary, I hope that I've left you with the message that an organized diagnostic approach is important, that treatment options are evolving and certainly need to be individualized, and that phenotyping, as we get more sophisticated in our phenotyping, may provide really significant guidance towards therapy. And the last thing is, as I've said, and you'll hear repeated many times today, is we need more research. The sobering reality is that patients with bronchiectasis suffer significant morbidity and mortality, and yet really can be offered few proven and effective therapies. And I hope that I can say something different when we do this course over the coming years. So thank you very much for your attention.